So good morning, everyone. So I've been tasked with the discussion of managing lung injury in patients with acute pancreatitis, and I have just two disclosures to make. One is that I'm not a pulmonologist by training, and second, I owe my understanding of the disease to my mentor, Professor Pramod Garg. So we all know that acute pancreatitis can be severe in a subset of patients, in around 20% of the patients who have a high mortality of around 40%. And this is largely driven by organ failure. And among the organ failures, respiratory failure is often the earliest to develop and is most common organ failure to develop. Although we have made great strides in management of local complications, we haven't really dealt with the management of organ failures in acute pancreatitis. So let us look at how the semantics first. How pulmonologists define respiratory failure is by a PaO2 of less than 60 millimeters of mercury, which is synonymous with a saturation of less than 90% or a P by F of less than 300. We as gastroenterologists use the modified Marshall score of organ failure score of 2 or more, which is synonymous with the PF ratio of less than 300 to define organ failure. However, there is more definitions and more terms which add to the conundrum. ARDS is a term which is the combination of acute hypoxemic respiratory failure with lung infiltrates which are not cardiogenic in origin. And even the definition of ARDS has evolved with the latest rendition, the new global definition telling us that we can even do away with X-rays, just presence of B lines on ultrasound, a saturation, SaO2 by FiO2 ratio less than 315, and it has obviated the need for even a PEEP. And there is another term, closely related term, acute lung injury, which is also now has been discarded. It was used in one of the older renditions of the ARDS definition to define PF ratio between 200 to 300. So we are left with a number of conditions, but all have in common is acute hypoxemic respiratory failure. So how does this acute hypoxemic respiratory failure develops? So in a subset of patients, they might have an dysregulated immune response leading to generation of cytokines as well as the pancreatic enzymes, which lead injury to the alveolar epithelial endothelial barrier. Moreover, in parallel, there might be increased lymphatic flow through the increased gut barrier dysfunction, and this lymphatic flow through the thoracic duct is directly driven into the pulmonary circulation. So this might also drive the injury in the lungs. So how does this injury actually translate to acute hypoxemic respiratory failure? Is that we could have edema in the alveoli, which decrease the surface area. For gas exchange, we have increased in interstitial fluid, which increase the thickness of the membrane, decreasing the gas transfer. We might have poorly ventilated alveoli leading to VQ mismatch. Moreover, there might be some injury at the end of the capillaries leading to microthrombi and dead space ventilation. And there can also be collapse due to the presence of effusion or mechanical ventilatory failure due to the severe pain, which add to the hypoxemia in these patients. How do we treat these? So we can't really do much by changing the other factors. If you think of the fixed principle, what you can do is increase the oxygen gradient across the alveoli. So even if you have a decreased surface area or increased thickness, you are able to achieve an adequate oxygen in the arterial blood. So we can do this by using certain low flow devices, reservoir systems, or high flow systems. We'll have a further discussion on these. So nasal cannula is one of the simplest and easily available devices. You can increase the flow rate of oxygen to up to 6 liters, and with every liter increase, you add upon the FiO2 by 4%. Rest of the minute ventilation is provided by the air which is sucked in from the nares from along the nasal prongs. It's easily available and easy to use. The only con being you can reach a maximum of 44%. Even if you were to rev up the oxygen flow rate above 6, you're not going to have an FiO2 of more than 44%. And obviously there is a problem in those who are mouth breathers. Then there are reservoir systems. They add to the fact that apart from the oxygen which is flowing in through the tubes, there is a reservoir of oxygen. So to provide the minute ventilation, part of it is provided by the oxygen which is flowing in, and part of it is provided by the oxygen in the reservoir bag. So you really don't suck in oxygen from the side because there are one-way valves on the side of the mask which just allow the CO2 to escape. So you can achieve a higher FiO2 using these non-rebreathing or reservoir masks up to 90%. But again, the cons are that they don't support really the work of breathing. They are kind of confining and they will impede eating in these patients. So there is another device, the Venturi mask. In cases where you need to provide exact FiO2, you need to know what FiO2 you are providing. These are based on the principle of air entrapment, and there are color-coded entrapment devices which you can fit below the Venturi mask, and you can have an idea about the exact FiO2 you are providing to these patients. But again, they come with the same limitation as with other masks. So now we have these high flow devices, particularly the high flow nasal cannula, which has come up, in which you can provide flow rates up to 60 liters and go with FiO2 of up to 100%. And the advantage are that apart from providing 100% oxygen, you are also providing some PEEP, around 3 centimeters of water, which helps in the work of breathing as well. The only downside is that the cost, availability, and you need special regulators to provide that high flow rate. Obviously, if you need to provide ventilatory support, not just oxygenation, then you have to either use non-invasive ventilation or invasive mechanical ventilation. And the only advantage of non-invasive ventilation as compared to invasive mechanical ventilation is that it prevents the risk associated with endotracheal intubation and ventilator-associated pneumonia. So if you were to choose one of them for your patient with acute hypoxemic respiratory failure and acute pancreatitis, what would that be? So obviously there is no one single correct answer. You have to look at the availability, you have to look at your patient. Suppose your patient is obtunded, then you got to intubate the patient. But if you had the freedom to choose from all of them, which one would you choose? So the Florali trial published in NEJM exactly looked at this, patients with acute hypoxemic respiratory failure, and they tested high flow nasal cannula, standard oxygen, and non-invasive ventilation, and the primary outcome of intubation at day 28 was no different among the 3 groups. However, the mortality at 90 days was lower in the HFNC arm as compared to non-invasive ventilation and standard oxygen. Probably in a post hoc analysis, they found that there was decreased intubation in the HFNC group in those with the PF ratio less than 200, not all the patients. So NIV scores, the HFNC scores over standard oxygen and NIV in this trial. So we at AIIMS New Delhi again did this trial, and this was among patients with acute pancreatitis, and we randomized the patients to oxygen therapy by face mask or non-invasive ventilation, and we were able to show that NIV decreases the need for mechanical ventilation and hospital-acquired pneumonia development as a composite outcome, and led to a shorter ICU stay as compared to oxygen therapy. So what should be the target we should be achieving once you have decided to oxygenate your patient or ventilate your patient? So there have been a number of trials, and over 25 RCTs have addressed this topic. And there is a meta-analysis which has shown that there is no benefit of giving liberal oxygenation. You can have your targets up to 90% of saturation. You don't need to go up to 96, 98%, because with more oxygen, you might be doing more harm to these patients. But of late, this thinking is changing because of this recently published trial in the NEJM, in which they had randomized patients to conservative versus liberal oxygen. They found that there was significantly increased mesenteric ischemia in the conservative oxygen group. And this has been further complicated by the fact that if you're using pulse oximetry for monitoring, particularly in dark skin tones, if you're thinking your patient is oxygenating well, the saturation on pulse oximeter might be above 96%, but in fact, if you were to do an ABG, you might, in 11% of these patients, you might find that these patients are actually having hypoxemia. Hence, we are moving towards slightly more liberal targets, maybe 92 to 96%, if not more. In patients with ARDS, the principles of ventilation remain the same, which we have borrowed from our pulmonary colleagues, that we give lung protective ventilation with low tidal volume. This is because we have increasingly recognized that ventilation with high tidal volumes might do more harm than benefit. A short duration of neuromuscular blockade helps because it decreases the dyssynchrony between the ventilator and the patient's effort. And moreover, cis atracurium in particular has shown to have pleiotropic anti-inflammatory effects. Restrictive fluid strategy is in, and proning these patients help because it decreases the VQ mismatch by allowing more ventilation in the dorsal part of the lungs. What about steroids? Although there is renewed interest in steroids with the recovery trial and after the COVID pandemic, but now it has been shown that even in non-COVID ARDS, giving steroids helps decreasing the days of ventilator, decreasing the all-cause mortality, as well as decreasing the ICU mortality in this recently published trial in Lancet Respiratory Medicine. However, what is not known that when to initiate steroid, which steroid is preferable and in what doses. So I'm aware Dr. Mahapatra has funding in this. He has recently secured a huge funding for testing steroids in organ failure, and maybe in a couple of years, we'll have the results. So take-home points for all this is that all respiratory failure in acute pancreatitis is not ARDS or acute lung injury. You have to identify and define respiratory failure appropriately, whatever definition you use. You got to treat the reversible causes. If the patient has a massive effusion leading to collapse, you drain the effusion, you will be increasing the ventilation definitely. Use fluid resuscitation appropriately. Choose your oxygenation devices and target carefully. And if the patient needs support in the work of breathing, then only ventilate. Thank you.